A lot of cancers, like colon cancer, breast cancer, are common enough in this country that they can undergo screening, colonoscopy, mammography. Pancreatic cancer is a rarer tumor, so it's not possible to screen the general population. If you had a test that was only false positive 1 in 100 times, you would still end up working up about 1,000 false positives to 12 true positives, just based on how rare pancreatic cancer is in the general population. So because of that, we don't do any screening of the general population. So we limit it to high-risk individuals. And so what we mean by high-risk individuals in 2014 are patients with a genetic predisposition to getting pancreatic cancer. So that may be known hereditary syndromes, like hereditary breast ovarian cancer, in which pancreatic cancer is the third most common cancer, behind breast and ovary. Or it may consist of familial pancreatic cancer, where we have at least two first-degree relatives who are directly connected, 2 cases of pancreatic cancer, in which there's not a known hereditary mutation. So we can't classify it as a syndrome. People are working on stratifying additional patients that may be at risk, such as new onset diabetics, but right now we don't have it enriched enough to make surveillance, because of this false positive issue, worthwhile. One, we're learning more and more about the genetics of pancreatic cancer. So we're starting to discover mutations that are very uncommon, but have a susceptibility for individuals getting pancreatic cancer, which may be from other associated genetic factors or environmental factors combined with it. So our knowledge is growing. There's many centers working on that. So they may not look like a classic cancer syndrome that we see, such as, like I said, hereditary breast ovarian cancer syndrome or Lynch syndrome. The other factor is that we're finding out other risk factors besides family history. There may be obesity plus smoking, and as people model this out, perhaps incorporating some additional genetic factors, we may be able to get an enriched population that we can do surveillance in. So if we can decrease our population, the general population, to 5 to 10%, and hopefully we can detect 80 to 9% of the pancreatic adenocarcinomas, then we may have an enriched population that doing surveillance is worthwhile.